Hello everyone, Hita White Azizi reporting from GIS2025 in Dubai. It's a pleasure to be here with Dr. Nicole Karam, Dr. Mahmoud Triana, and Dr. Mohammed Al-Hiji in our roundtable talk. We'll discuss TEER versus medical directed therapy in secondary mitral regurgitation. We start with Nicole. Nicole, how has the new guideline distinction between ventricular and atrial SMR changed your diagnostic tool and therapy strategy?
Oh, it's very important because we've been seeing a lot of those patients coming to our clinic and being secondary MR, and it's definitely two different chapters. And if you look even at the management of those patients, it's totally different. When you are dealing with ventricular SMR, now the guidelines recommend a class 1 indication for TEER whenever it's feasible, and then to discuss other options in other cases. While for atrial FMR, it's a whole new different chapter. The LV is doing okay, the problem is the atrium, and here the guidelines recommend instead to go first to surgery that will be more complete and allow the closure of the left appendage and also ablation. So it's a whole different way of managing. It was about time to get a different distinction between the two.
Mahmoud, in Reshape HF2 showed reduction in hospitalization, no mortality benefits. Do you mean it's shift in on the TEER towards area intervention before left ventricle remodeling happens?
Yeah, I think so. The way I take it is Reshape is kind of a continuation of COAPT. So COAPT had a much sicker patient population, much more advanced disease. So when we started going into the earlier phase of disease, it's obviously going to be more difficult to prove a mortality benefit, but it shows you kind of the gradations. So the earlier you intervene in the disease and the less severe the MR, the less dilated the ventricle is, you'll still have a significant benefit, but not as much for mortality, whereas the COAPT was a much more advanced cases. So I think it gives us a much broader range of patients that will benefit, and then we can actually inform to patients much more which patients to target and which ones will benefit.
Thank you. Mohammed, in your interventional workflow, which clinical and imaging red flags make your decision toward earlier intervention before waiting and with medical therapy?
Yeah, I think as mentioned with Mahmoud, is very important to identify those patients earlier before they get further deterioration in their LV function. So first of all, we need to understand that the ERO cutoffs for mitral regurgitation intervention and those trials was 0.3, not 0.4. So we have to educate the general cardiologist that 0.3 is actually the indications for intervening and fixing the mitral valve before it's affecting the LV function. So we don't want, we want the patients to have good LV function, okay? We want them to have a good LV dimension, meaning that they don't have significant dilatation of their LV. And those patients, and as Nicole mentioned, are the ones who have class 1 indications for MTR therapy.
Now I have a question. It will be hard for you as interventional cardiologist, and I will answer each of you. Which imaging parameter make your decision strongly against TEER and stay with medical therapy?
Oh, honestly, if medical therapy is already optimized and the patient is still symptomatic, then I will read real red flags to really not do the procedure. I mean, the question is not whether we can keep the patient with medical therapy. The question is whether we should consider an alternative such as assist devices or transplant, and not necessarily whether it is medical therapy or edge-to-edge. But leaving asymptomatic patients with medical treatment alone, I guess it's like a condemnation, a life sentence. So,
Mahmoud?
Yeah, I mean, exactly the same. I think optimized medical therapy, if they still have persistent in spite of medical therapy, the main technical portion is the highest risk is when they have some degree of stenosis. So then you really have to be sold much more, because when you go into that case, you're much more likely to leave with a higher gradient, less fulfilling result. And so in that case, maybe I need more patients to be sicker, more symptomatic, that I'm willing to try it, where I won't try as early in a patient with some degree of stenosis.
We don't want to make mitral stenosis instead of regurgitation.
Exactly. So you'll still do some cases that are in the yellow zone, but those patients need more symptoms to push you.
Yeah. Mohammed?
Yeah. So first of all, we need to understand that mitral clip therapy is very safe. Okay. We know from a lot of registries, from COAPT trials, that even with patients with advanced heart failure, you can perform mitral clip therapy in a safe fashion. I think the anatomy is very important. So you need to know the anatomy. Okay, you need to know, the expectation for that patient, how much reduction you will achieve, how much stenosis you will have if you, for example, clip that patient. So depending on the let's say a risk-benefit ratio for that particular patient based on the anatomy, then that will usually lean you one way or another to perform a mitral clip or MTR in general in those patients or not. But in general, if the patient is symptomatic, they have COAPT-like criteria. It's a class 1 indication, and you usually need to try you need to try to perform MTR to help those patients, reducing their heart failure hospitalization and improving their survival.
Thank you very much. We conclude our talk. Thank you very much for the great discussion.